Hello. So now the COVID surge is increasing in our country. So I have a very small presentation about COVID-19. It is nothing but laboratory clues for practitioners. What the laboratory is going to tell the practitioners how to deal the current COVID-19. So the blueprint of the session very simple. Know your enemy. So what is the latest update on COVID-19? What are the new characters? And Indian scenario. That is important. We should know what is happening around us. Third, what is the laboratory clues for practitioners? That's all. Make it very simple. So now know our enemy. Yes, SARS-CoV-2. Everybody knows. You studied in WhatsApp and all social media, flooded with messages. But now we should know about the new variants. It is not as what we have seen on 2020, 21, 22 time. Okay. So it underwent mutation. Mutation is a natural process. Any organism which multiplies, whether it's a bacteria or virus, even human being, okay, they undergo some changes, mutation for the purpose of adaptation, survival. So two important mutations, delta and another one is omicron. That we are aware of that. Many omicron people caused disease in the previous wave. B1187, like many numbers are there, don't worry. Currently, the new variants, descendants of Omicron, are the culprits. Number one is NB181. Number two, LF7. Number three is JN1. And there is recombination between Delta and Omicron. Recombination between Delta and Omicron, that is called KFG. Sorry, XFG. Previously we have XE like variants. XFG. These are all the variants. Currently available variants in our country. The recent outbreaks happened because of these variants. And classification of SARS-CoV-2 variants, because variants is a new term for clinicians, because clinicians simply ask any mutation. I want to learn 4 points. Number one, what about the transmissibility? Because of the mutation, it is more transmissible or less transmissible? If it is more transmissible, it's a problem, public health problem. So number one, transmissibility. Number two, very very important, is severity. Because of new mutation, it become more severe. That is the dangerous, alarming situation. Number three, will it obey for any drugs, or it develop some drug resistance for existing drugs if the drugs available? That is important. Because of mutation, it become resistant. We need to search for new drug. Okay. Number four, whether it obey for the vaccines. The existing vaccine is ideal to treat this condition or not. Is it okay, or shall we develop new vaccine? For example, influenza. The avian flu vaccine not useful for swine flu, but both are caused by influenza virus. Like that. That is the understanding. These are all the what worries of clinician. What about laboratory people? Will it obey for the same PCR test? Is same PCR test is useful to treat or to diagnose this condition? That is the doubt for laboratory people. So WHO created some names. You need to understand what it is. Basics, not much. One is called variant under monitoring. That means they may affect transmission. They can immune escapism is there, but there is no much evidence. So don't worry about it. That is the take home message. But some changes happened that you should know, but that there is no massive impact. Classical example, NB181. Currently here, NB181 is shortly called as Nimbus. The nickname is Nimbus. NB181. Number two, variant under investigation. That means there is increased transmissibility, increased immuno escape. It causes few disease, few cases are available, maybe. So what is it? Preliminary signs of growth, advantage of phenotype change under active study. Example, LF7. So it also not much worry. This is important. Variant of concern. If anything they say variant of concern, then evidence of increased transmissibility, increased severity, evidence available, proven cases. So we need to do something. Example, previously Omicron, BA1, BA2, all these are variant of concern. When the WHO announces variant under monitoring, variant under investigation, don't worry about it. If they say it is variant of concern, then we need to worry about it. Got it? Some code words are there, like that. This is a code word. Recently, one tragedy happened. The word, everybody aware of that now. The word, what is called, we should not hear the word Mayday. Mayday means everything is over. Like that. If variant of concern means this is started. Okay, like that. Next is, so initially variant of monitoring, after some period of time, they turn to be variant under investigation. Okay, next is variant under investigation. Some conditions they turn to be variant of concern. For example, conclusive epidemiological evidence of increased severity transmission, impact on vaccine or diagnosis, the variant of concern. You got the point? So anything first start as a variant under monitoring, variant under investigation, finally they turn to be variant of concern. Sir, this is laboratory language. We people are clinicians. Make it easy. Nutshell. Variant under monitoring, just to watch it like a tiger. A tiger is in the forest. You are on one end of the forest, tiger is another end. Just you watch it. Oh, tiger is there. Careful. Variant under investigation. Study it. The tiger saw you. Yes, you have seen me. Early signs of trouble. Keep an eye out. Next is when the tiger start moving towards you. You need to run. You need to save yourself. That is called variant of concern. Act on it. Very simple. Watch it, study it, act on it. How it is going to help for practitioners? Okay, for example, anything comes under variant of concern, there should be a global response. You need vaccine updates, travel advisories, new diagnostics, everything. We need to do a lot of things because we are acting on it. Variant under investigation guides local surveillance, intensification of local surveillance. What happens? What is the new strain? What about the character we need to do? And variant under monitoring, closely watch but no change in public health. What is existing, you can follow the same thing. So currently what we are getting is only variant under monitoring. So don't expect any new guidelines or new diagnostic methods, anything new, no need to expect, because still it is variant under monitoring. When it turned to be variant of concern, definitely there should be change in the guidelines or change in the treatment. Some change should be there. Variant of concern is nothing but voluntarily it wants the change. Okay, right. Next is current Indian scenario. So that is called INSACOG, India SARS-CoV-2 Genomic Consortium. What they did actually, they did the study and they announced current variant or NB181, LF7, JN1 and recombinant XFG. In this, which I marked, which is called NB181, I'll write here, NB181, and the yellow marked people are the responsible for current outbreak, the June month, May month outbreak. And these two people, one is NB181, the nickname is Nimbus. It is still variant under monitoring because some mutations on the spike protein. Spike protein is helping in attachment. If there is a mutation, there will be more attachment, increased transmissibility. And it reported in Delhi, National Capital Region, Maharashtra, contributing rising cases. This is one culprit. It is variant under monitoring. Another one is XFG. It also variant under monitoring. It's Omicron variant and it's a recombination between Omicron and Delta. Maharashtra, Tamil Nadu, Kerala, Gujarat, many places. And higher transmissibility reported and it escaped from immune system. These are all warning signs, but still has not been linked to severe illness because of we already have herd immunity. Vaccines definitely help us. How? Suppose the original virus, after mutation, it changed 20-30%. 70% is original, 30% changes will be there. Same way, if you take the vaccine, your protection will be 70% for the virus, 30% it can escape. So, if unvaccinated person, the effect will be 100%. In vaccinated, it will be only 30% because of the reason vaccine directly as well as indirectly herd immunity. Okay, everybody is immune to certain extent. Next is come to the point, laboratory clues for practitioners. Number one, when to collect sample. Like previous one, better you take first 5 days of symptom of onset, fever, cough, sore throat, because that time highest viral load will be there. After that viral load comes down, you may get the sensitivity may be affected. Number two, preferred sample type, same. Nasopharyngeal swab is ideal. But in case of rapid antigen test self-testing, also you can use. Nasopharyngeal swab is the gold standard for COVID-19 diagnosis. Next is laboratory clues for practitioners, timing of asymptomatic contacts. That is the problem. Because if one person is affected, previously we have beautiful guidelines. Now no cases. So in case of asymptomatic, if case of symptomatic contact, immediately do the test. Asymptomatic contacts, collect sample 5 to 7 days post exposure, because today I got the exposure. Today itself, you can't expect the positive result. So wait for 1 week. But in between the 1 week time, any symptoms appears, do the test immediately. Next is, it's a $1 million question. Why it is called $1 million question? Yes, everybody have the doubt. Lot of mutations are there. You are finding the genes in PCR. Will the old PCR is useful or not? That means current PCR kits can detect new variants, or we'll go for new PCR kits. Answer is here. Laboratory people are dancing. What does it means? Good result. Okay. No need to go for new test. That means current PCR kits can diagnose. No need to go for new. Major RT-PCR kits, our country detects N gene and E gene. Okay, some of the kits detect all three genes, but our country program, we will not detect exclusive S gene. For example, Japanese people, they detect only S gene. Those people, wherever S mutation is there, they need to change the kit. For us, it's not like that. See this picture, it will help you. So these are all the important antigen. Nucleic acid gene we are detecting, and E gene, envelope, and spike protein. Among the three, here only the mutation occurs. But our kits mainly concentrating on these two people. Okay, so RT-PCR targets these three genes. We are getting these two. We are getting Omicron by another way. Other country people, they purchased new kits to get S gene, Omicron. But our people had our own style. What is it? They detect the S gene. Other two genes are present. S gene they detect. If the S gene is detectable, it is not Omicron. If S gene is not detected, other genes are detected, it may be Omicron. Rule out method, like MCQs. If you put MCQs, sometimes if you know the answer, you can shoot. Otherwise, you can eliminate others. You can end up in one answer. Like that. It is second category. Other country people, they purchase new kit for S gene. Our country, same S gene. If S gene is there, it is not Omicron. S gene is not there, other genes are present. It's SARS, but it may be Omicron. Okay, like that. Next is rapid antigen test. Usually self antigen test. Our country setup, my personal opinion, it may give false information to the patients because the sensitivity is 50%. Once a person do the test, if he positive, negative means we cannot say 100% negative. It's not a gold standard test. Okay, if a person is negative, then whatever is sick, he will not come to the hospital because he thought I am negative for the test. I did the test. It is negative. I am not COVID. He can spread. So better you consult, if symptoms develop, you consult the nearest physician, nearest healthcare center to get advice from them. Okay. So useful for quick diagnosis, especially in symptomatic individuals. Less sensitive in asymptomatic or very early infection, it is. So that is a problem. But it's using for self-diagnosis who don't want to go to hospital. If you develop the symptoms, you do the test. If positive, consult the doctor. Even though if it is negative, you are not ruled out. Okay, better go for RT-PCR. Next is, this is another big problem. CT value in RT-PCR. People have a lot of myths and misconceptions. CT value not for clinicians, only for microbiologists. Okay, a value which we can say whether it is positive or negative. Because clinician want to result. Sample is positive or negative. Okay, this value will not help the clinician for discharge or treatment or admission, whatever it may be. So lower CT value means higher viral load. Higher viral load, it indicates. Okay, it's not a direct viral count. It's an indirect marker. Higher viral load. Where higher CT count means lower viral load. Low transmissibility. Possibility of low transmissibility we cannot say, because CT value may be vary from different reasons. When I am doing the process sampling, if I am taking little sample, I am taking nasopharynx, if it not reach it properly to the nasopharynx, the swab, it has little amount of virus. It's amplification technique. If I put 100 virus, 100 got amplified into 1 lakh, for example. Here, suppose if I put 1000 virus, then it become 10 lakhs or 1 crore, like that. So it's very difficult. We can take a decision based on CT value. You can take the decision the sample is positive or negative. That is the laboratory people. We will do. And repeat PCR and discharge not recommended in our country. No need to do PCR on discharge. Discharge based on clinical cure. Not needed. As per latest guidelines, Ministry of Health and Family Affairs guidelines, clinical recovery not based on negative PCR. Because PCR may be positive for even 1 month, 28 days, 30 days, even 40 days also some people found positive for PCR. Clinically they are good. So if clinical cure is there, clinical parameters are okay, you can discharge. Next is antibody based tests. Some laboratory people are using, do not use for diagnosis. It is useful. Every test is useful for the intent purpose. Here we can use it for surveillance purpose, not use for diagnosis. Epidemiological survey, how many people developed immunity after vaccination, how many people develop immunity after infection. You can do zero surveillance, not for diagnosis. Antibody in SARS-CoV-2. HIV, we are using antibody for diagnosis. So don't mix it, don't compare. So HIV, we are using the antibody test, we are treating. Why not this? Because both are different. HIV, what about the incubation period, this incubation period, outbreak, lot of factors on that. Next is genomic sequencing. It mainly for, now we are talking about variant under monitoring, variant under investigation, variant of concern. This is the variant NF7, JN1, okay, like that. X sub G, all due to genomic sequence. It is performed for variant surveillance mainly, not for routine diagnosis. That also we done in designated laboratories or network laboratories by INSACOG. What is prognostic marker? Same as what you studied in 2000. Still we are maintaining the same thing. Start with CRP, interleukin 6, D-dimer, ferritin, LDH. These are all prognostic markers. I used to say, I read the meme course of PCR in 2021. CRP, first PCR, next CRP, finally CPR. Got it? That was the course previously. Now it's not like that. Because of vaccination, we stop with PCR. Even we won't allow increasing CRP also. Okay, right. Next is role of procalcitonin. we can differentiate from bacterial pneumonia. The etiological agent is bacteria or thing. We can certain extent. Sometimes we have overlapping superadded infection also available. Because of procalcitonin increased, you cannot say he is having only viral pneumonia. Maybe mixed pathogen, superadded. And what about multiplex respiratory panels? Ideal, because if a person comes with ILD, interstitial lung disease, it may be due to influenza, it may be due to Nipah, it may be due to SARS-CoV-2, or it may be due to some of the bacterial pathogens. For every time, if you do one test for each, very costly, cumbersome. For that, we have multiplex respiratory panels, multiplex PCR. One PCR can detect multiple pathogens. Use that. Time saving, cost effective. Okay. Where there is the COVID mimicry suspected, you can use it. All mimic like COVID. Finally, two more. LFT and COVID-19. Yes, many times COVID-19 mimics as hepatitis. So follow LFT. Monitor AST, ALT levels in severe cases. And CBC, any infection. CBC is the fundamental baseline. No need to explain. In case of lymphopenia, neutropenia, thrombocytopenia may indicate poor prognosis. CBC is important. And when to suspect false negative? Number one, the patient is symptomatic, strong history of contact, family people, 3-4 people affected, he is also, but the test is negative. That time you can think of false negative and repeat the test. Repeat the sample after 24 to 48 hours. That time you can use bronchoalveolar lavage, like lower respiratory specimens, sputum, like that. And take home message, final part. Number one, current RT-PCR kit remains gold standard for effective diagnosis. Even the new variants come, because new variants comes by spike protein mutation, but we are detecting other nucleocapsid in envelope. Number two, no need to repeat PCR at the time of discharge. Don't wait for PCR to be negative for discharge. It's not a discharge criteria. Use biochemical and inflammatory markers, CRP, interleukin 6, D-dimer, for disease monitoring, not for RT-PCR alone. RT-PCR for diagnosis. For prognosis, you can use these parameters. Timely sample, early proper technique, and right test of choice are crucial for accuracy. Overall, the recent COVID-19 wave in India is driven by Omicron derived, mainly NB181 XFG in the June 25th. Marked by rising cases but remains largely mild thanks to widespread immunity and vigilant public health measures. That's the main reason. Continue standard precautions, stay updated with vaccination guidelines. That is important. Don't believe false messages, unauthenticated messages by social media, because the social media spread is 100 times faster than the original viral spread. And don't go for quacks and what is called unauthorized treatments, unproven unauthorized treatments in the name of tradition. Anything, even tradition treatment will respect, but it need to be proved. You prove it, then treat it. Don't treat and prove. Okay, right. And authorities are maintaining strong surveillance and response system. That is the reason we are getting a lot of news. If the authorities are not maintaining the strong surveillance system, we won't get the data, we won't get the information, we won't get the feed to the newspapers or news channels. Every day they put news channels. 1 case is there, 5 cases there. How? Because of strong surveillance. That is the need of the hour. So with this, I complete my presentation on laboratory clues for clinicians in COVID-19. Hope you all enjoyed this. Okay. So thank you all. See you with another one video.